Hi everybody, my name is Kevin King, and today I want to talk to you about CT scan utilization in trauma. And for a historical perspective, this is an image of the very first CT scanner developed in the United Kingdom in the early 70s. Obviously it was a head-only CT scan and didn't quite give us a resolution that we enjoy today. So let's do a quick case study. We have a rollover motor vehicle accident on a freeway. Everybody self-extricates. You know, I guess I ought to go to the hospital and get checked out, so they all accept EMS transport even though they're not having any symptoms. And if they show up at my facility, because of their mechanism, they're going to get a pan scan. So, exactly what is a trauma pan scan? Well, trauma pan scan is a brain, C-spine, thorax, abdomen, and pelvis, all CT scan, with the body component being done with contrast. As we've noticed, this modality, to put it mildly, has been growing in popularity over the last decade and a half, and especially with the advent of the high-resolution, high-speed CT scanners. And the reason is it shows us some really awesome pictures. We can see very clearly the pathophysiology or the pathology that's going on in these patients. Really provides us with some valuable and interesting information. So the people who think, yeah, we've got to do pan-CT scanning, they say it saves lives, a lot like this St. Bernard is in this story. And then there are those of us who are concerned about the amount of CT scanning we're doing, and we're just concerned that we're not really driving mortality or helping patients, we're just making them glow. So let's kind of talk about this. What are the concerns regarding CT scanning? Well, in the first part of the 21st century, the rate of CT scan utilization roughly doubled and in some cases tripled. What we worry about, honestly, is one, the cost. The cost to the patient is between $10,000 and $20,000 for a pan-CT. It's a heck of a lot of money. We also worry about the radiation exposure. Trauma is a disease of the young, and so we worry about the radiation exposure. We know that as we expose people to radiation in their younger years, they tend to have a higher rate of radiation-associated cancer. So where does that leave us? What are we supposed to do? Well, we can turn to the literature. And I'd like to talk to you about kind of a study that's been pointed to over the last year or so. And this is done by Nicholas Caputo and group, published last October 2014. And it's a meta-analysis of 7 studies that met their criteria. And they compared selective scanning, scanning where the physician said, I believe this patient needs a chest CT, versus just pan scanning everybody who met certain trauma criteria. And their main outcome was odds mortality. When they looked at all this data and smashed it all together, they came up with some fairly compelling data. It looks like selective scanning has a higher rate of mortality than pan scanning does, even though the injury severity score is significantly lower. Seems like case is closed. But of course, as with everything, there's a catch. We look at the study itself, when we look at this meta-analysis, number one, it's a retrospective meta-analysis. All the data in the study is retrospective. There are no randomized prospective controlled trials looking at this question. They were highly reliant on one data set. If you look at all the patients included in this meta-analysis, one data set accounted for 65% of the total patients looked at. And then all of these studies that they looked at, there was no standardized protocol. Some patients were seen in trauma centers, some were not, some crossed international boundaries. It was just kind of a mishmash of trauma registry data. And then the study really suffers significantly from something called stage migration, which is a kind of study bias. Let me explain what stage migration is. So if we take a patient and they had a rollover motor vehicle accident, they have a femur fracture, a liver contusion that you identified because they had abdominal pain and you scanned them, and a facial laceration, that gives them an injury severity score of 14. However, if you pan scan that very same patient, who by the way has no headache and has a GCS of 15, so under Canadian head CT rules, doesn't really meet criteria for a head CT, you find a tiny cerebral contusion that is clinically insignificant. Their injury severity score turns into a 23. You can kind of see how pan scanning folks and finding those asymptomatic injuries that have no clinical impact can really skew the injury severity data in a very interesting direction. So what Sir William would tell us is we need to use clinical judgment. And the American Academy of Surgeons say in ATLS, use clinical judgment when deciding your imaging modality. So how does that work out? A study done by Gupta and group out at UCLA did a prospective observational cohort looking at this very question. And what they did is they took all of the patients that were seen in their trauma center and agreed they were going to pan scan them all. But after the clinical exam, but before the CT was done, they asked the ED attending and the senior surgeon to rate which parts of that pan-CT may not be necessary. And their primary outcome was how often did that undesired CT scan show something important that drove clinical care. And here are their results. A total of 2,804 scans were performed, and 992 were deemed unnecessary by the emergency physician. Out of that 992, 102 had an abnormality, but only 3 or 0.3% were considered critical abnormalities. However, the authors disagreed as to exactly what a critical abnormality was. And so here are those 3 critical abnormalities out of this 2,800 odd scans. One was a T8 burst fracture in a patient who presented with paraplegia. The other one was a patient with a GCS of 15, otherwise asymptomatic, who had a tiny subarachnoid hemorrhage. And then the last one was a gentleman who showed up with 10 rib fractures, a lung laceration, and that was clearly evident on the chest x-ray. So it is questionable whether or not these were even critical findings. Kind of depends on how you define that, but take that into consideration when thinking about this study. But importantly, what percentage or how many patients had a bad outcome because something was missed on an undesired CT scan, and that was 0. Now granted, this is a prospective observational study, but it does raise some compelling thoughts at least about our ability to judge which patients need CT scans and which don't. So what should we be doing? You know, I'm not a pan scan kind of guy. I like to think about what I want to do with my patients and make a decision about how I want to take care of them. And if you're like that, don't be frustrated by our colleagues, either surgeons or other emergency physicians' insistence on CT scan. The problem is if you see a lot of high acuity trauma, like our trauma surgeons do, everything kind of looks like a nail. And so they want to hit it with a hammer, where we have a slightly broader, at my facility, we see all trauma, where the surgeons see all of the severe trauma. So there is a little bit of bias in their practice in terms of what they see and what they expect, so we need to be sensitive to that. I recommend that you use your clinical judgment. We have a series of excellent clinical decision rules, Canadian Head CT, Nexus, Nexus Chest, a myriad of decision rules that are well validated, that have been demonstrated to help us out with this, and use those decision rules when deciding your imaging strategy. So, in summary, there are no good studies saying that pan-CT is the way we should be dealing with trauma patients. They just don't exist. I still think that clinical judgment is king. That's what we should be doing. Don't neglect a careful history and physical exam when you're evaluating your trauma patients, and use those clinical decision rules. And with that, I'll answer any questions.